And I believe you're going to be doing item number 5 now. Is that correct?
Yes.
That would be AB 339, Gordon Healthcare Coverage, Outpatient Prescription Drugs, Long-Term Health Care Facilities, Complaints, Investigations, and you're going to be presenting on behalf of Assemblymember Gordon.
AB 339. Yes, I'm here to present AB 339 on behalf of my colleagues, Assembly Members Gordon and Speaker Atkins, who are not able to join us today. I want to thank the committee for their analysis of the bill. On behalf of the authors, we are taking the amendments discussed with the chair. These amendments include amendments to assure coverage of the AIDS drug cocktail, adding a 4-year sunset on the provision of the bill related to the drug cost sharing cap through January 1, 2021, and simplifying and clarifying amendments that eliminate several provisions and add language stating plainly that health plan formularies may have fewer than 4 tiers. A mock-up of the amendments is being passed out. Thank you. The amendments are a result of technical assistance provided by the administration. The authors commit to working further with them and stakeholders if the measure moves forward today out of this committee. AB 339 is driven by 2 fundamental consumer protections. First, drug formularies should cover medically necessary drugs without discriminating against those with conditions like HIV/AIDS, multiple sclerosis, epilepsy, or other serious conditions. Second, consumers should not be discouraged from taking medically necessary drugs by cost sharing of more than $6,000 for a single drug. The important consumer protections in AB 339 include a cap on prescription drug copays and coinsurance of no more than $250 for most coverage and $500 for bronze, a definition of prescription drug coverage tiers, which reflect the policy adopted by Covered California, and other consumer protections. AB 339 builds on existing federal law and guidance, existing state law and guidance, and policy developed by Covered California with respect to prescription drugs. Thank you for your consideration, Mr. Chair and Senators. I respectfully ask for your aye vote on behalf of Speaker Atkins and Assemblymember Gordon.
Thank you very much. Anyone like to speak in support?
Thank you, Mr. Chair and members. My name is Sawait Sium. I'm here on behalf of Health Access California. We are pleased to sponsor and support this bill and thank Assemblymember Gordon for authoring it. AB 339 prevents discrimination against individuals with health conditions by establishing standards on cost sharing for prescription drugs. As indicated, this bill builds on recent federal rules and regulations that reiterate the anti-discrimination provisions of the Affordable Care Act. This bill also builds on existing state law and guidance and does mirror action taken at Covered California. This is a bill about basic consumer protections. A recent study found that the average consumer has about $2,300 in liquid assets in their checkings or savings account. Today, we expect the average constituent to pay over half of what they have in their account for a single prescription in the first month. Imagine you are someone who has a chronic illness such as MS, rheumatoid arthritis, or HIV/AIDS, and you're having to take a prescription that costs over $6,000 for a single prescription in the first month. How would you pay for this prescription? What would you do? Today, we ask consumers with chronic conditions, the most vulnerable among us, to pay this ridiculous cost for life-saving prescriptions that they rely on. This bill, again, is about basic consumer protections. While we sit here and present this bill to you, there are consumers out there who are struggling to pay for their life-saving medication. Individuals are having to split pills, they're skipping doses, and some are just choosing not to pick up their prescriptions because they're having to make that difficult choice. Do I pay for my rent? Do I pay for food, or am I going to pay for my prescriptions? These are the choices that individuals with chronic illnesses are having to make today. The opposition will talk about impacts to premiums and actuarial value. I'm here to tell you today that what we found during the Covered California workgroup process is that the impact to premiums and actuarial value will be zero. Some health plans reported that there would in fact be zero impact, and some said that the impact could be 0.3% a year. The opposition will also talk about the rising cost of drugs. We get that, but whose responsibility is it to negotiate with pharmaceutical manufacturers? Is it the consumer, or is it the health plan and the pharmacy benefit manager? This bill gets the consumer out of what one legislator appropriately described as the clash of the titans. So we present this bill to you today and respectfully request your aye vote.
Thank you, Mr. Chair and committee members. I'm Ann Donnelly, here on behalf of Project Inform. We're an HIV and hepatitis C advocacy and education organization that was founded around the time of the beginning of the AIDS epidemic. We're here to proudly support AB 339 because it protects access to effective, comprehensive, and quality health care and treatment for Californians with HIV and other serious medical conditions. Here in California, after the implementation of the ACA, the Affordable Care Act, we saw some serious problems with some plans, including formularies that did not cover the National Institutes of Health recommended HIV drugs, and that includes the HIV single tablet regimen. We also saw some plans that put all or most of the HIV drugs on the specialty tiers, and as you know, that leads to extremely high consumer cost sharing. As a result, many people with HIV stayed on the AIDS Drug Assistance Program and other Ryan White programs, which meant that they incurred a tax penalty. But more importantly, it meant that they also couldn't take advantage of the obvious health and cost benefits of having comprehensive health insurance. From our perspective, the benefit design of certain health plans not covering drugs recommended in national treatment guidelines, and in some cases making the drugs cost prohibitive or discriminatory against people with HIV. In fact, the federal government was prompted by the nationwide HIV drug problem in part to cite the exclusion of the single tablet regimen and placing all drugs to treat a specific condition on the highest cost tiers as examples of what could be discriminatory plan designs, benefit designs. AB 339 ends this practice. It says that some drugs to treat a condition have to be on the lower cost-sharing tiers. It caps drug costs for most people at $250 per a 30-day prescription. It ensures that Californians with serious health conditions get the medically necessary drugs they need to ensure good health. We, along with Health Access, Consumers Union, and many health plans, were part of the Covered California work group that looked at the delivery of specialty drugs. AB 339 really builds on the results of that process and extends the same reasonable consumer protections to individuals with coverage in the employer market. At Project Inform, we really understand the tension between drug prices and coverage, and we share the concerns about the costs of some high-cost drugs and the impact, particularly on consumers, but also on the system. As a founding member of the Fair Pricing Coalition, we negotiate directly with drug companies to keep HIV drug prices reasonable and to ensure that they're available as quickly as possible. However, it's also true that over the years since we started working on HIV, people with HIV have moved from a life expectancy of about 43 days to a normal lifespan, and we have ended the transmission of HIV from HIV-infected moms to their babies. And that's in large part because of effective HIV drugs. Now we also have an HIV drug that, when used appropriately, can stop new infections. So the hope of ending this epidemic really depends in large part on these drugs being accessible and affordable to Californians living with and at risk for HIV. We need AB 339 to ensure that everybody with a serious health condition or at risk for one, not just people living with HIV, but including people living with HIV, have access to the drugs that they need at a price they can afford. We ask you to join us in supporting AB 339. Thank you.
Thank you. If you can just state your name and position at this point.
Jerry Jeffy, representing the California Chronic Care Coalition, supporting the bill.
David Ford for the Association of Northern California Oncologists, in support of the bill.
Jasmine Gordon on behalf of the California Black Health Network, in support.
Rebecca Gonzalez, National Association of Social Workers, California chapter, in support.
Moira Top on behalf of Biocom, in support.
Sarah Flox, California Labor Federation, in support.
Betsy Emholtz for Consumers Union, in strong support.
Elizabeth Landsberg with the Western Center on Law and Poverty, in support.
Rebecca Hollowell on behalf of Epilepsy California, in support.
Stephen Schultz, Arthritis Foundation, in support.
Seth Bramble here on behalf of the California Teachers Association, strong support.
Rand Martin on behalf of the AIDS Healthcare Foundation, in support.
Mike Montgomery, Congress of California Seniors, support.
Matthew Lewis on behalf of CalPERG, in support.
Thank you. Opposition?
Thank you, Mr. Chair and members. Nick Luizos on behalf of the California Association of Health Plans. We're opposed to AB 339. And our opposition to this bill is fairly simple. Legislatively designing health benefits increases premiums. And so we can legislatively create the best benefit packages in the world, but if no one can afford them, that's pretty useless from our perspective. And this has been demonstrated time and time again. The independent analysis of the introduced version of this bill does show premium increases of close to $400 million on individuals and employers. Now, indeed, Covered California has recently enacted in the small group and individual markets drug copay caps with the assistance of my health plan members that are part of the exchange. But they ran analyses of these caps, and the results demonstrated some interesting things. Indeed, the first-year impacts on premiums were negligible, but Covered California did project that over a 3-year period, prices could increase by 3%, and that's a pretty significant percentage from our perspective, considering all of the cost drivers in the healthcare system. They also mentioned in their analysis that there is a high degree of uncertainty with the new introduction of drugs, the prices of those drugs, particularly specialty drugs, which makes projecting future year premium impacts difficult. And as we stated in previous committee hearings, some analysts predict 12 new blockbuster drugs being introduced in 2015. And a blockbuster drug is typically defined as a drug that generates annual sales of at least $1 billion for the company that creates it. These are probably reasons why Covered California also stated that the annual evaluation of the pharmacy benefit is necessary to adjust benefits as needed. This is to protect premiums and to protect the actuarial values of the products. While we do acknowledge and appreciate the sunset that's being added to the bill, it is a 4-year sunset, and drugs are expected to get more expensive, not less expensive in the meantime. And, to bring up last year's poster child for expensive drugs, that was Sovaldi last year at a whopping $1,000 per pill. The son of Sovaldi, Harvoni, the follow-up pill is priced at $1,300, actually $1,350 per pill. That's pretty expensive. We do acknowledge, and these are patent-protected products, so the idea that our health plans have the strongest hand in the negotiation process over these prices, there's at least some question of that. We do acknowledge that the bill is inching closer and closer to the regulations that were developed at Covered California. So we want to thank the author, the sponsor, and the chair for those developments and credit them for that. But if this bill passes committee today, we are not opposed and frankly would like to engage in future conversations about potentially tightening the language even more. But we remain opposed at this time. And with your indulgence, Mr. Chair, if I could just close by saying that we appreciate your leadership in evaluating underlying cost pressures, including drug prices, as they have been a subject of committee hearings here. If this bill is enacted, we collectively have no excuse for continuing to ignore the underlying price of drugs. We need solutions. In our view, it starts with transparency of drug prices, and we're happy to actually be on the same side of the proponents of this bill and the chair of Assembly Health in trying to achieve that. And so we do believe it starts with transparency and a rejection of this Orwellian concept that was stated in a previous hearing of this committee of self-attested value to society-based pricing of drugs. But we think that kind of an approach is ill-defined and will lead to cost increases. So we would invite Assemblymember Gordon, if he was here, to join us in a discussion over transparency and other solutions that actually get to the root problems of cost drivers. So thank you.
Thank you. Anyone else?
John Caldwell from the Pharmaceutical Care Management Association. We share CAP's concern that it's unwise to place in statute caps that have yet to be enacted. In addition to being premature, the Covered California emergency regulations are complicated, difficult to comply with. This problem is highlighted by the new language in the bill that attempts to mimic the emergency regulations. The so-called 50% rule appears to conflict with what is being proposed by Covered California. And there's this language: the drugs or drugs assigned to the lower cost tiers pursuant to this paragraph shall be the drug or drugs that were most often prescribed during the immediately preceding plan year, unquote. This appears to require the brand pharmaceuticals in the same class that have been on the market the longest, and thus the most often prescribed, would get favored status. In some cases, this would be the most expensive. In some cases, it may not be. So we don't see the reasoning behind that, and we think it's just going to require redoing the tiers on an annual basis based on what's the most popular drug. Another issue, AB 339 essentially forces coverage of more expensive brand HIV pharmaceuticals that are in single tablet form when less expensive brands or generics in multi-tablet form are available. AB 339 requires health care plans and insurers to cover a single tablet drug regimen instead of less expensive multi-tablet regimen, unless the health plan or insurer can demonstrate, quote, consistent with clinical guidelines and peer-reviewed scientific and medical literature that the multi-tablet regimen is clinically equal or more effective or more likely to result in adherence to drug regimen. There is at best limited research on such comparison, and without such proof, the more expensive single-tablet product would have to be covered. As the Assembly Appropriations Committee analysis noted, the burden of proof to refuse coverage of these drugs, according to the bill's provisions, appears very high, essentially meaning they would have to be covered. This provision would completely eliminate any incentive for the manufacturers to negotiate for inclusion on plan formularies. The language in this provision is based on an example in an HHS memo. There's nothing in federal regulation or statute that creates the impossible burden of proof found in this provision. There's still another problem with AB 339.
We can kind of wrap it up.
Okay. AB 339 contains a lot of language from the Notice of Benefit Payment Parameters. One of them is the mail order provision. That doesn't take effect until 2017. This bill would require everybody to have it in effect in California in 2016.
Thank you. Anyone else? Just please state your name and position.
Stephanie Watkins on behalf of the Association of California Life and Health Insurance Companies, also opposed.
Maureen O'Haron representing Molina Healthcare of California, which participates in Covered California. We oppose for the reasons stated.
Chair members, Luis Sanchez with Blue Shield of California in opposition.
John Winger on behalf of America's Health Insurance Plans and Express Scripts, also in opposition.
Teresa Stark on behalf of Kaiser Permanente. We have an oppose unless amended position. Want to thank the author and the sponsor for the amendments thus far and talking with us. And there's a little bit more work to do on the bill, but we're getting close, and also want to strongly echo the comments about the need for sustainable drug pricing, the underlying problem here. Thank you.
Mira Morton here on behalf of the California Chamber of Commerce, also strongly opposed.
Mandy Lee on behalf of CVS Health, strongly opposed.
Julie Broyles here on behalf of the California Association of Health Underwriters, also opposed.
Dan Chick with HealthNet in opposition. Thank you.
Thank you. Anyone else? Questions from any of the members? Seeing no questions from the members, is there a motion? Move the bill by Senator Pan. Comment. I'll make a couple. I'd just like to make a comment. I'll be supporting the bill. Yes, I agree that there are conditions that need to be dealt with, especially very expensive ones. I believe that we need to make sure that the consumer doesn't have to go bankrupt. And if you look at what Covered California done in regs, I think that's what this bill is mirroring. A little concern is that they're done in regulatory. If we do this statutorily, then that's something that's indefinite. The reason why I am supporting it is because of the sunset, to kind of figure out and see how we can control the cost to the consumer. But there's something I think we need to really have a discussion. There's an underlying problem, and it still deals with overall controlling costs to the healthcare system, and that's the increasing costs of prescription medications. At the end of the day, so what's going to happen? So you're going to have lower payments to the consumer, but yet if you have escalating drug costs, guess what? All those costs are going to be passed on to the consumer in the form of premium increases throughout the entire system. So I believe that that's something we definitely need to continue to do to control costs, but also to protect the consumer, and I will be supporting the bill. So would you like to close, Assembly Member?
Yes, Mr. Chair. This bill provides important consumer protection for vulnerable patients with serious needs, and I respectfully ask for your aye vote.
Thank you. We have AB 339. Gordon, do pass as amended to appropriations. Call the members, please.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Aye.
Mitchell, I. Monning. Nielsen. Pan. Pan, I. Roth. Wolk. Wolk, I.
Currently has 4. We'll place that bill on call. I think it was Bonilla, Senator Assemblyman Bonilla. You were here first. I can't remember. Stone, like, we're file order? Okay. It's file order, but she's been here a long time. Are you okay if she goes first, or does it? I know I've seen her there a long time, and I feel.
I sure do. Thank you.
Senator Bonilla.
Thank you very much, Mr. Chair and members. I present to you today AB 1060, which establishes the Cancer Clinic Trials Foundation, whose mission will be to increase access to cancer clinical trials for all patients, especially women and underrepresented communities. Currently, only 3% of eligible cancer patients participate in clinical trials in California. 3%, which is really astounding. That number is even lower, with less than 1% of patients actually participating. At the national level, only 5% of participants are from underrepresented communities. Basically, what the bill does is provide and establish a grant program that would provide funds to applicants for activities which would reduce the participation barriers. And I really want to make sure that those who have come to testify have the opportunity to speak, so I'm going to stop right here and introduce to you today Brittany Powell, a young former cancer patient who continues to participate in a clinical trial, and Dana Dornseif, president and founder of Lazarus Cancer Foundation.
Okay. Hi, my name is Brittany Powell, and I ask for support of the Assembly Bill 1060, which would create Cancer Clinical Trial Foundation help to increase access for cancer patients like me to life-saving clinical trial opportunities. In the spring of 2009, I started having mild back pain. My pediatrician thought I was overexerting myself in basketball and suggested Motrin to see if the pain would go away, but the pain did not go away. In July of 2009, I was diagnosed with giant cell tumor of the cervical spine. As you can imagine, this was devastating for our family. I went through 6 painful surgeries only to find that the tumor had grown back even more aggressively. After 4 months of chemotherapy, the tumor grew back immediately and aggressively, and I started losing my ability to walk and hold objects. While searching online, we found a clinical trial in Los Angeles that was having amazing results with the type of tumor that I had. We decided immediately to go to Los Angeles to see if I would qualify for the study. But the travel and the expenses were a burden to us. At this time, my cancer was ruining my health and my life. Our economic misfortune at our home were growing as well. Our house was even in for foreclosure, but we knew we just had to fight and try to get to this clinical trial. It was a matter of life or death for me. While interviewing for the trial, the medical center told us about an organization named Lazarus Cancer Foundation, which provides navigational and financial assistance to patients who want to participate in clinical trials. We contacted them immediately, and they provided us with emotional, logistical, and, of course, much-needed financial support. After they helped enroll me in the trial, soon after I started the trial treatment, we began to see amazing results. After 6 months, the tumor could not be seen on a CT scan. Lazarus paid for our airfare, hotel, and plus rental car every few weeks. To this day, I continue on the clinical trial, and Lazarus still supports our trips. With this, which is why I am here before you today. Through the grant that will be made possible by AB 1060, more people will have access to the patient's navigational service like I did. The bill will also help cancer patients learn about trials so they can receive the newest treatment when traditional treatments have failed. For these reasons, I urge you to support AB 1060. Thank you.
Thank you. Please proceed.
My name is Dana Dornsife, President and founder of Lazarus Cancer Foundation, Danville, California. I'm here in support of Assembly Bill 1060, which will increase access to FDA-approved clinical trials for advanced stage cancer patients and the medically underserved. I come to you with personal experience of the emotional, physical, and financial devastation that accompanies a cancer diagnosis. My brother-in-law, Mike Miller, succumbed to pancreatic cancer at the age of 44. After Mike failed standard of care, I took on the challenge of searching for alternate treatments for him in FDA clinical trials. This experience led to my revelation about the total disconnect between the research bench and the patient bedside. In 2006, I founded Lazarus Cancer Foundation to address this disconnect. We removed the barriers to clinical trial participation for patients and improve equitable access to cancer care. Patient participation is critical to the successful completion of a trial and approval of a drug, and yet only 6% of doctors suggest clinical trial participation to their patients. Astonishingly, almost 50% of clinical trials fail or are significantly delayed due to lack of patient enrollment. The vast majority of patients and caregivers are left to their own accord to research their clinical trial options. Clinical trials offer medical breakthrough opportunities to advanced stage cancer patients who have no other treatment options. Clinical trial drugs are offered free of charge. However, travel to the site, lodging, rental cars, etc., the cost of a travel companion, and many medical fees are not covered. These costs create financial toxicity for patients at a time when they can least afford it, creating a financial barrier to participation. Cancer doesn't discriminate. If we're to develop treatments and cures for everyone, we must have people from all segments of our population participating in clinical trials. But historical, cultural, and socioeconomic factors also create barriers to minority participation. Overall, only 3% of eligible patients participate in trials, and of those, only 5% are from racial or ethnic minority communities. In conclusion, the burdens of clinical trial participation are placed squarely on the shoulders of patients who are simply not able to bear them. This creates a vicious cycle that sabotages the enrollment process, extends the length of time to completion, drives up costs, delays getting drugs to market, and most egregiously, prevents patients from being able to participate in potentially life-saving trials today because they may not have it tomorrow. Assembly Bill 1060 addresses these gaps in cancer care for advanced stage patients like Brittany and the medically underserved, and I urge you to support AB 1060. Thank you.
Thank you. We have no more remaining time. Anyone else would like to speak? Just state your name and position.
I'm Marilyn Simon, Brittany Powell's mother, and I am in support of this bill.
I'm Brianna Powell, Brittany Powell's sister, and I'm in support.
Maureen Higgins, representing Biocom, also in support of the bill.
Thank you. Anyone else in support?
Good afternoon, Mr. Chairman, members. Janet Lopez, representing the University of Southern California, in strong support.
Thank you. Anyone else?
Laura Fitzgerald, on behalf of the California Life Sciences Association, formerly known as CHI and Bay Bio, in support.
Thank you.
David Ford for the Association of Northern California Oncologists, in support.
Thank you. Any opposition? Questions, comments from any of the members? Been moved by Senator Mitchell. There's support on both sides. Chair is recommending the support. Would you like to close?
Thank you very much. I believe this is really the beginning of an innovative approach where we hope to have a public and private partnership to address the barriers to patient participation in clinical trials. I'm hoping that what we really end up with is going to be a national model of making sure that everyone who lives in California and who is facing these unbearable situations at least has this option of removing barriers to get the opportunity, the chance of a clinical trial. We believe it creates a very, very strong program that's going to help everyone involved and, as I said, hopefully be something that would be a model nationwide. Thank you, and I ask for an aye vote.
Thank you. It's a AB 1060, do pass as amended to appropriations. Call the members.
Hernandez.
Aye.
Hernandez, aye. Nguyen. Hall. Mitchell. Aye. Mitchell, aye. Monning. Aye. Monning, aye. Nielsen. Pan. Aye. Pan, aye. Roth. Wolk. Aye. Wolk, aye.
Currently has 5. We'll place that bill on call.